everyone. Good evening, and thank you so much for coming to be a part of our talk tonight. My name is Alicia Rogers, and I am the Organizational Director for Generational Health under the leadership of Dr. Jamisha Ford. I have the pleasure tonight of introducing our next installation in our series on improving health and advancing the health of our communities, and also introducing our speaker. So just a little bit about generational health. We are an organization made up of resident physicians, medical students, and health advocates with a mission to increase and promote health in communities of color that will endure through the generations. Tonight, you will hear from one of our founding members, Dr. Morgan Jivens, who is a psychiatry resident at Indiana University, who is passionate about mental health in communities of color. So I will now turn it over to her and bring up the slides.
Good evening, everyone. Thank you for joining us. We'll go ahead and jump right in. So tonight we'll be talking about Black mental health matters. This is something that is very dear to my heart. It's one of the main reasons that I chose to go into psychiatry. And it's the population I want to serve is my community. You can go ahead and do next slide. So tonight we will be talking about some barriers to care that we have, some signs of suicide. So Suicide Prevention Day was actually last Friday, so this is right on time to speak about this. How you can help if someone is in crisis, and what to ask your provider if you need help with mental health care. Head and next slide. So in the population, Black people are about 13.4% of the population. I happen to love this slide because I think it gives a great overarching view. And of that 13%, 16% have reported having mental illness in their life. That's over 7 million people, and combined, that is more than the populations of people in Chicago, Houston, and Philadelphia. So this does affect like someone you know, and it's important that we are getting help for this. Next slide. So there are, just like there are health disparities for everything, there are mental health disparities. So we talked about that 16%. Of that 16%, only about 1 in 3 are receiving care
because of COVID. I mean, not COVID, it's with the rain.
And
yeah, I'll take her.
I'll pause just for a second. So yeah, there are about 20% of Black people are likely to experience a serious mental health issue, and that's greater than the general population. For all mental health overall, we are actually less likely to experience mental health issues. We are unsure if that's a true statement or just we tend to not report these symptoms as much. However, research does indicate for Black children, they do have a higher rate of suicide than white children. So it is affecting our community and we are losing people. And it's important that we are getting people that help. On top of all of that, Black people with mental health problems are actually more likely to end up in jail and prison than receive the help that they need compared to other races. We also receive lower rates of offered therapy and medication. And we have to think about all of the historical adversity that we have been through. We know that that puts us at a higher rate for mental health issues, and that this is something that is very prominent in our community. Next slide. So next, we're going to talk about our barriers to care. So the main ones we're going to talk about is like cost and like access to care, stigma, and minimization. Next slide. So I really like this quote. Is don't give in to stigma. A diagnosis does not determine who you are or what you can do. So there is the number one reason that Black people do not get mental health care is because of stigma and how we approach it and how we think about it as a community. Next slide. So there are two types of stigma that we deal with. The first is called double stigma, and this is something that is put upon us by society. So it is the prejudice and stereotypes that people have, that the general population have about Black people, and that they have about mental health and how those are combined. And we think about those things all the time. When you do something, when you have an activity or you perform an activity, we think about how other people are going to perceive those. And so this has a really huge, causes a really huge deficit of receiving care because we wonder what other people are going to think about us, including our own families. We also have self-stigma. And so this is how we view mental health ourselves. People who have mental health issues, especially Black people, report more shame and embarrassment in regards of their mental health issues. They feel like they can't talk to their family about it, and they feel like it shows a sign of weakness. So this is really important to acknowledge and think about if this is something that you have ever thought about, and how you view mental health and how your family around you views mental health and if they're receiving the care that they need. As minorities, younger people are usually disproportionately more affected by stigma, and interesting enough, people with college degrees are also, because they feel like it's something that they should just be able to overcome themselves. So they don't feel like they need to go out and get help with this. One other thing that plays a huge role in stigma is that religion affiliation. So there's a study that says about 87% of Black Americans report some type of formal religion. And that is known that it's always been this kind of thing to, you should pray about it and all of this stuff and not get help. And that is not necessarily true, that you shouldn't pray about it. Having a religious affiliation actually is a protective factor in regards to suicide, but that doesn't mean that you
Your food on your table.
in other ways. Next slide. And then I'm just going to ask if everyone could mute their mic for me. Thank you. So the next thing we're going to talk about is minimization. And this one I was actually very surprised to learn about, but also something that I see that is commonly done that I even do myself. So minimization can be very closely related to stigma. And it's when we do a self-depreciation. So I like to use the example, if you're having chest pain and you don't really want to worry about that chest pain and you want to say like, oh, it's not that bad. But if you are having chest pain, it's very important to get that checked out. That is not considered normal, but it's the downplaying of the importance of negative events or negative symptoms or actions. And so this happens a lot when we talk about mental health, especially due to the stigma. It's something that we don't want to recognize and we don't want to be aware of. So we'll be like, oh, it's not that bad. Oh, I'll deal with it later. And all of these things are minimization that prolongs going to get help. Or one that we really do is compare ourselves to other people's situations. So it'll be like, oh, well, it's not as bad as something over there, or I don't have a reason to be depressed, or look at all the stuff that I have, like I have a house, I have a job, and this other person doesn't. Depression and mental health doesn't really work like that. It doesn't choose people according to what they have or what they don't have. So you can have depression or bipolar or schizophrenia or the whole list of mental health disorders without having something that caused it necessarily in your life. So it's important that we are aware of the minimization we're doing in our health so we can get care in the proper time period. Next slide. So now we're going to talk about access to care. This one is really important. It's a little harder for us as individuals to control it, but it is really important that these are things that you look for with government. So like these are the things that you vote for your insurance. When we talk about cost right now, this is one of the most common reasons that Black people are not getting mental health care. They are unable to afford it. As a general population, we are less likely to be insured, and we are more likely to actually lose insurance during our lifespan than any other race. On top of that, even if you have insurance, the rate of psychiatrists who accept Medicaid, Medicare, or private insurance has drastically decreased in the last 15 years. To put it even more in perspective, on average, it can cost anywhere from $100 to $300 to go to the psychiatrist without insurance. And it can be even as high as $500. So this is something that is really important that we need to be aware of, because people are not getting care just simply because they can't afford it. And there are more important things in their life that they have to pay for, and that should not be a reason to not receive care. Next slide. The next access to care is location. So in Black communities, especially primary care providers in Black communities are less likely to be in the same vicinity as a mental health care provider. Primary care physicians are usually trained to give a certain level of mental health care, but for those serious disorders, they are not prepared to take care of those. So it's really important that we are finding ways to transport people to appointments and increasing mental health care providers in the community. This can be really hard because, as we know in medicine, people who tend to serve in those communities are people who look like the people who live in those communities. In psychiatry, Black psychiatrists are only 2% of the population of working psychiatrists right now. So it's also important that we try to find ways to increase that number and to excite people into going into the mental health field. One way that we can kind of decrease these numbers are mobile clinics, which have been on the rise. However, right now, like only 14% of mobile clinics actually serve minority populations. And of those 14%, only 8% are mental health focused. So they're still not reaching all of these people in the communities. And this is super important because we know that people with chronic mental illnesses like bipolar or schizophrenia will decrease their admissions of going to the emergency room or hospital inpatient admissions by having care located near them.
Pause it real quick. Pause it real quick.
Next slide. So I think this really shows the importance of what we are dealing with. So there was a survey done in 2019, and it showed that suicide was now the second leading cause of death in Black Americans in ages 15 to 24. So I think that just highlights how it's drastically increased even in the last 5 years, especially with suicide. We are losing people, and we need to give focus, just like we give focus to diabetes or heart diseases. Next slide. So this is kind of the breakdown that we're looking at when we think about people who are even considering suicide. So serious thoughts are when people just are ruminating on wanting to die, not wanting to live anymore. And then we go to making a plan. So when they start to make a plan, they have a place that they're going to do it. They have what item or what they're going to use to kill themselves. And then we have attempt. When we talk about attempt, we talk about that they did not die during this process. We don't like to use like a failed suicide attempt or a completed suicide attempt. We don't like to give like positive and negative to those words. Next slide. So this now here lists some of the most common disorders that are actually associated with suicide. So we have depression, which is a mental disorder that is characterized by a persistent low mood, loss of interest in activities, and it causes significant impairment in daily life. It's like when people try to find joy in something recently and they just can't seem to find that joy. We have bipolar disorder, which is a combination. They have periods of depression and they also have periods of mania, which is a very elevated mood. It can be elevated or they can also be irritated or irritable, and they tend to not sleep and have unlimited energy. We also have, next we have PTSD or post-traumatic stress disorder. This is a disorder that is caused by exposure to actual life-threatening experiences, threatened death, serious injuries, sexual violence. So this doesn't have to happen directly to the person. It can happen directly to the person. It can be seen or witnessed by the person happening to someone else. It can even just be overheard happening to a close family member or someone close to the person to cause PTSD. After that, we have schizophrenia. This is a disorder that affects people's ability to organize their thoughts, feelings, and behaviors. We normally associate psychosis with this, which is when people are having hallucinations, like they might be hearing voices or seeing things that other people can't see, or even having paranoia or delusions. So they believe something that just isn't tangible or possible. And the last one we have on this list is borderline personality disorder. Excuse me. This is a mental disorder that's characterized by an unstable mood, behavior, and relationships. So these individuals tend to have a lot of mood swings. It kind of seems like they do something we call splitting. It's like very black and white, and it's either good or bad, and they have a hard time regulating their mood. Next slide. So next, we're going to talk about some risk factors. Excuse me. Risk factors for suicide. So one of the biggest risk factors is a previous suicide attempt. Once someone has tried to commit suicide one time and it has not worked, their threshold for trying the next time is that much lower. They realize what comes with the process of trying that, and they still have those feelings of wanting to die. And so they are more likely to attempt again. If someone has a substance use disorder, that also increases their likelihood of suicide. Using substances comes with a whole list of other social factors that plays into this role of wanting to live or not. Excuse me. Chronic pain or diseases. This is a big one because when people have chronic pain, they don't see any way out of that chronic pain. Even if it's being treated, it's very hard to keep up that hope of getting over this when they don't see a light at the end of the tunnel. A family history of suicide is another factor, especially if they knew that person who completed suicide. Excuse me, who did suicide, died by suicide. Because it's already like a disposition and a way someone else died, and it puts the almost kind of like the option in their head. Next, we have access to firearms or other weapons. So this isn't a risk factor that's necessarily should automatically put up your alarms. But if there are, this is something that's very important, especially with children too. If there are access to firearms or other weapons, that is something that's very easy, even if it's like impulsive decision in that moment and they don't actually want to die. This is one that can cause that can risk that very easily. And so we usually instruct patients to lock up their firearms or even just remove them from the house completely. Lack of access to behavioral care is an important one, and this is one that really affects the Black community, as we talked about earlier. If you don't have access to behavioral care, you can't get the help that you need. And so you're just really unable to find any way out, and you feel very isolated. The last one I will talk about on this list is recent release from jail or prison. This one is really important because we all know there's an increased amount of Black Americans in jail. And when they are released, there's not always a way to adapt back to being out in the general population. And so there is this depression because for years they had a scheduled regimented day that now that they don't have, and it's an adjustment period that they don't always seem to get through or are able to handle. Next slide. So these are some immediate warning signs of suicide. These are things that should, like red flags that should make you really want to think about getting someone help. If someone is really fascinated with death, or they talk about always wanting to die, if someone talks about wanting to feeling empty, hopeless, or no reason to live, this is a very important one because there has been research done that shows that Black people are actually more likely to have these feelings of sadness and hopelessness and worthlessness compared to other races. So this is one that is really important to look out for in family and friends. When people talk about feeling trapped, like there's no way out, no solutions, when they talk about being a burden to others. So a lot of times, even when people are depressed, they will make statements like they don't want to be a burden to others. They feel like it would be better if they just weren't there, people would have less problems. These feelings of guilt that they're putting on other people, that them being there is putting on other people or other pressures. Next is if you see someone getting their affairs in order or giving away possessions or saying goodbye to family and friends, that is a huge red flag, especially if that's not something that they had talked about before, such as making a will. Those are things that you should kind of question them about and see what's going on here. And make sure that this is something that, if this is suicidal thoughts, that you are getting them the help that they need. Next slide. So there's immediate warning signs and serious warning signs. These are ones that can go back and forth besides the making the plan. The making a plan is one that is a serious warning sign, you want to get them help. So when we talk about making a plan, there are different ways that you can figure this out. Like I recently had a patient, I'm working with children right now, whose mother brought this patient into the ED because they found out that they were looking at ways on their phone to kill themselves. So even if you find something like that, it's important to bring that person in and get them evaluated. It's also like if someone's bought a gun recently and they've never talked about owning a gun, that's should be another red flag for like making a plan. People who have extreme mood swings all of a sudden, like very sad to very happy or calm. So you've had a friend that's been depressed for a while and all of a sudden they seem very happy or calm and it's a sudden switch. This is something that you should make you ask, like, are you thinking about suicide? Increasing drug and alcohol use is another one that you should really think about. Next slide. So these are some protective factors. There are things that we can do in our everyday life that will protect us from actually doing suicide. So effective behavioral health care, that is engaging in therapy or psychiatric care. So medications or going to talk therapy. Connectiveness. So we know that individuals who have a good support system, a good family, friends, community, they are less likely to commit suicide. Even so, that they feel it's even more important that they feel responsible to those families or friends, that they should be there for them. That will be a huge protective factor in committing suicide or not. The next is life skills. This life skills really talks about coping skills. So coping skills are a way that you can learn how to tolerate or deal with stressful situations. And we all use coping skills every day in our life. So I'm gonna ask you guys to be involved a little bit. Can you guys name some healthy and unhealthy coping skills for me that maybe that you use or that you've seen? You can actually put them in the chat below and I'll call some of them out and we can talk about them. Yeah, so the first one we got is unhealthy eating and smoking. Yes, eating is a huge one. The way we can say it in like layman's terms is like stress eating or overeating. It's using that food and those comfort foods that you need to feel better about yourself. Smoking is another big one. For people who smoke, when they tend to feel stressed, they feel that need to smoke that cigarette. And for most people, they know it's unhealthy, but they still feel the need to do it anyway. Shopping. Shopping is one that can be negative and it can be positive, depending. If your shopping is out of control, like you are spending a lot of money that you don't actually want to be spending, but it makes you feel better, that would be an unhealthy habit, coping habit. If this is shopping every now and then and it made you feel better or relieve some stress, you could count that as a healthy habit. Some other healthy ones I see are working out. That is a great one. Working out is one of the best things that you can do for yourself. It's a great coping skill. It actually helps decrease depression and increase your mood. So if you had to choose one, even just going for a 20-minute walk can change your whole entire day. Talking. So this is one that is also a little bit on the fence. So talking out what you have to say and what your feelings are can be really great. If you are constantly venting about the negative things that are going on in your life, that actually keeps you in that space. So if this is something that you're doing all the time, and you keep coming back to it, it actually keeps you in that negative space. So it can be a negative coping habit too. Another one I see is boxing and yoga. Those both fall into the working out and great ones. Journaling. Journaling, I feel like, is one that has been on the rise lately, and some people like it and some people love journaling. Some people, like myself, I have a very hard time getting into journaling, but it is a really great way to write your feelings down and get them out there and let that be a release for you. And it's a way that people also use to process their feelings, and let themselves digest what they're talking to. Unhealthy, bottling up inside. That is a very unhealthy coping skill. You will have feelings. Your feelings are valid. They are something that you should be aware of. They're something that you should think about and digest. So do not bottle them up inside. They will have to come out in some way. Unhealthy, validation through social media. This is a huge one for all of the social media users. Most of us probably are. Social media is not real, as honestly put it. So it shows all of the good things, and it can actually make you more depressed because you are seeing all of these things that look like they're going right in someone's life, which might not necessarily be true. And then you start comparing yourself to that. And so it's important to almost limit your time of social media and be aware of where that falls in your life. And then I'm scrolling. What about crying? All of your other ones are really great. But I love this question about what about crying? So I think it's important. Crying can be fantastic, right? It's a release of emotions. Most of the time we don't know what to do with those emotions. I would say this is a healthy coping habit overall, as long as you are crying at the right time and the right reasons, right? So sometimes people will like cry to get their way or for other reasons. If it's a release of emotions and a way to cope and get rid of that stress, it does fall in the healthy habit. And I would suggest everybody cry. It will change your life. Don't be afraid of it, definitely not. And let me see if I didn't mention any of these. Meditation or prayer. Those are two really great ones. Meditation can be very hard to do. It's something that you have to practice at, or prayer. So religion is very important. It's another bullet point in this protective factor. Religion is super important, and especially if you have cultural beliefs or religions that are against suicide or consider suicide to be wrong. That can be a huge protective factor for you, and it can also give you a sense of peace. The last one I will talk about on the protective factor list is self-esteem or self-purpose. So when we have jobs and we feel like we are making an impact in the world, you are less likely to commit suicide because you feel like you are affecting people. Next slide. So this is, you can put your answers below, because I feel like this is a very interesting question. Does asking about suicide increase a person's risk? Perfect. You can hit the next arrow again. So you guys are correct. No, it doesn't. Studies have shown that asking people about suicidal thoughts and behaviors does not increase the risk of such thoughts. I ask this question every day, and people will not, the reaction normally is, if they are not having suicidal thoughts, like, no, why would you ask me that question? So it won't increase their thoughts, but it is the best way to get a direct answer. So if you have a person that you are wondering if they're thinking about suicide, asking them directly is the correct way to get that answer. Next slide. Okay, so next we are going to talk about what to do if someone is in crisis. This is a very interesting thing. I don't know, I guess I have the question, has anyone ever had to go through this process before? And you don't have to share, it's just something to kind of think about and what that process looked like for you if you don't. So the first thing I have listed on here is go to the nearest emergency room. If you have a person who is contemplating suicide, as Black people, I would take that person to the emergency room if that is possible. The next one on here is call 911. And this can be problematic and scary because we have all seen in the media where someone is having a mental health crisis and they end up being shot by the police. And so I think my advice is to be, if you have to call 911, be as clear and thorough as possible. Tell them exactly what is going on. Tell them that this person has a mental health history. These are important so people know what they are coming into when they arrive to do this. The reason that you call 911 is in Ohio, we have something called pink slips or like a 5122. And so police have the ability to sign what we call pink slips. This will allow you to put someone on a 72-hour hold. They will take them to the hospital and they will then be able to get the care that they need. And that's why that is the first step. So to be able to sign that, it has to be a police officer, a parole officer, a sheriff, a licensed counselor, or a medical professional are the only people who can sign those. You can hit the next button. So the other things that you can do is call the National Suicide Prevention Line, and I have listed that number there, or you can even have them text the crisis text hotline. So if you have someone that you're not sure or you don't know what to do also, these are also numbers that you can call or text, and they will give you information and they will give you help. And they are people who are trained to talk to people who are having suicidal thoughts. So this is also a good route to go. And they can tell you if they need to go to the hospital. You can even call with the National Suicide Prevention Line. If they are worried, they can ping that location and send help. Next slide. And so it's important when we talk about getting care for this, that we know what to ask our providers, that we know that we are getting treatment, the treatment that we need and the treatment that we deserve. So we want to know that our providers are culturally trained to serve you. So don't hesitate to ask your provider any question that you have, but this just lists some of them that I think that are important, especially because as a Black psychiatrist, we are only 2% of the population. So it is very hard to find it might be very hard to find someone that looks like you, and it might be very hard to find someone in general because there is just not enough of us in the mental health care field. So it's okay to ask if they have ever treated any Black people, if they've ever been culturally trained to treat Black mental health. The way that we tend to talk to our providers is a little bit different than other races, right? We tend to be more direct, and this can be perceived in different ways, but if they've been trained to understand that, then they understand, right? And that's something important. It's important to ask if they can understand your background, if they have an open mind view to understand your background and how things in your life have caused your personality or how you respond to things. If they're open to different treatments and working with you. So there's actually been research that, as with psychiatry, Black patients tend to get over-talked more during their sessions than any other race. So it's important that you speak up for yourself and ask the questions that you need to ask. Next slide. So here I have listed some recommendations of websites. There are actually a ton of websites out there, and I could not list them all. So there are recommendations of places that you can go to find Black mental health care. Some things like Therapy for Black Girls. It is a podcast and a website. It is amazing, and it just talks about how to deal with certain things that happen in your life. Beam, which is the first one on this list, it actually gives toolkits and education for maybe if there's a new diagnosis or something that you want to understand, or even coping skills that if you wanted to develop more. I see that we have one question in here. Do we have any other questions? Feel free to put them in the chat. So the one I see, it says, what do you recommend for patients to do who may not have the confidence or weigh the risk of speaking in a way that might lead to dismissal from a practice, AKA white fragility? That is a very interesting question. I think that you have to weigh what's responsive for you. So even if you don't ask these questions to your provider when you go in, I think it's important for you to reevaluate when you come out how you felt about that session. If you felt taken care of, if you felt listened to, if you felt like your symptoms were taken seriously, all of those are very important, because if any of those answers are no for those, then I would suggest trying to find a different provider.
Hey, Dr. Jivens, I have a question.
Yes.
You spoke about mental health and the association with drugs, but you didn't really discuss the particular association, like which one is the chicken and which one is the egg. Can you talk on that? Speak about that.
Yeah, so it's not always a chicken or an egg thing. One of them doesn't necessarily come first. People who already have substance use disorders are higher for suicide and vice versa. So it kind of, when you are using drugs, it lowers your impulse threshold. You are more impulsive. A lot of the drugs that we use can cause a whole different host of symptoms like paranoia or hallucinations, or even they can just depress your brain and give you a depressed feeling. So the drugs can almost put you in a state of depression and cause you to want to commit suicide, or because you are using drugs, you might be more likely and the depression might come first. Comorbidities or like combined disorders with mental health and drug use are a huge thing. And they normally involve treatment for both at the same time. Did I answer your question, Dr. Ford?
Kind of. I guess I was speaking more so of people who are depressed and self-medicate with drugs.
Oh, okay.
And people who take drugs and become depressed, or even are thrown into psychosis from some drugs, or if they were psychotic before and started drugs.
So like the occurrence of those that happening and the likelihood of them committing suicide is the question?
I'm not speaking about suicide specifically, just like mental health in general.
Okay.
Because I just have a lot of patients who use recreational drugs and they say that it helps with their mental illness. You know what I mean?
Oh, yes.
And a lot of these drugs are psychoactive, and I don't think people understand that. So I just wanted you to speak about that a little bit.
Yeah. So what she's touching on is for recreational drug use, a lot of people use them to self-medicate for mental health illnesses. And they can cause other issues besides that. So they can cause someone to be what we call psychotic and have hallucinations and hear voices and see things, or they can cause depression. So they don't really solve the issue. They almost normally make it worse. And I think that is a misconstrued notion when people talk about using drugs and them making them feel better. There are a lot of other risks that go along with them that can cause worsening mental illness. And the other question was, when educating other white and non people of color providers, how do you go about informing them that Black people aren't monolithic to you? This is a difficult one. I think people have to be open to wanting to know that, right? I think that it's important that we start educating in things like residency now and getting experience with other races and other cultures. I don't necessarily think it's in the job of one individual to educate someone else that they're different than them, right? Or that they might need a different approach or a different experience. I think it is that person's jobs themselves to educate themselves on who they are going to be serving. I think there's a hand raised for the Johnson family.
Hi, Dr. Jivens. Can you hear me okay?
Yes.
Okay. I have a question about, so if you know someone, whether it's family, friend, neighbor, whoever, who suffers from mental illness, that they are truly a harm to themselves, to the public, they may have battled with it for a very long time, untreated mental health, just because they've refused help or in denial or whatever the reasons are. Are there any laws that will allow a psychiatrist or doctor, someone to sort of mandate that they get the help that they need? And then if so, how do you go about that process per se?
Yeah. So that's going to start with, it normally starts with the pink slip. So you normally end up calling the police, or the EMS will bring them to the hospital. They will be examined in the hospital. They will say that they will need to stay there for at least 72 hours. After that 72 hours, the physicians can put in what they consider as an affidavit. And that means that they are going to take them to court. And so that automatically extends them to about at least 10 days. It can be somewhere to up to 14 days before they have a court date. In that sense, you are petitioning for a commitment. I will have to look up Ohio law. I know I'm practicing in Indiana, so I know Indiana. So I can tell you a little bit about that. In Indiana, we have a temporary commitment and we have a regular commitment. A temporary commitment is 90 days. That means that person is committed at least to psychiatric treatment for 90 days. They cannot refuse medication. They are normally inpatient for the majority of that time. And that is, if you keep it for 90 days, that is, you believe that person will be stabilized within that 90 days if they continue to take this medication. After that 90 days, you can petition for a regular commitment, which is reviewed every year. And so the person might not stay inpatient all of that time, but they are committed to having to take their medication and follow up with mental health providers. And so if that person does not take their medication, they can legally be picked up and returned to the hospital who has the commitment on them and brought inpatient to restabilize them.
Thank you very much.
You're welcome. Any other questions?
We will give folks a chance also to place any other questions in the chat. And Dr. Jivens, if you have any contact information for folks attending that may have some follow-up thoughts, could you also drop that link for them as well? We want to take a moment to send a great thank you to Dr. Jivens for a fantastic presentation and an important talk that begins a conversation of how to start these life-saving conversations and to be proactive in our communities. And also for all those who are attending tonight, thank you so much for being a part of this, for being engaged and being committed to the health of our communities. We just want to bring your attention to a few things. So she has placed her contact information in the chat, and as well, Dr. Jamisha Ford has also placed a link for feedback. We would super appreciate if you could share your thoughts with us. It's very quick. It's, I think, 4 questions, pretty short. We would just love to know what your thoughts are and things that you'd like to see for us to do in the future. Just a little heads up. Our next topic will be either the end of this month or beginning of November. Wow, next month is October. That's crazy. And we will be speaking about COVID and its impact on our communities. And what we know is just a place that can be a point of contention and conversation. So we want to speak about this from a place of honesty and integrity, and validating a lot of concerns and questions that people in our community have. And the thing that will be kind of unique about this approach is we'll be having a health advocate, one of our team members, Tiandra Finch, speaking, along with a fellow medical student and colleague who's done extensive research in our community, who is a great insight on this topic as well. So please stay tuned for more information. You can follow us on our Instagram account at OurGenHealth. And we also have a website under the same name, OurGenHealth.org. And we will have all of those dates updated for you in the very near future. So again, thank you for attending tonight, and we wish you all a good evening.